Dear Chairman, dear ladies and gentlemen, thank you very much for the invitation to this interesting symposium. I will now present on advances in Alzheimer's disease PET biomarkers. These are my conflicts of interest. Talking about biomarkers, we need to be aware that different factors are suggested to be involved in the generation of Alzheimer's disease. This is amyloid pathology constituted by extracellular aggregation of beta amyloid protein. This is intraneuronal aggregation of neurofibrillary tangles built up from tau protein, and both of these pathologies are suggested to result in neuronal injury constituted by synaptic dysfunction and neuronal loss. These categories of pathology are referred to as classification A, T, and N, and we are today in the fortunate situation that we do have imaging biomarkers available which allow us to capture all three categories as constituted by amyloid PET, by tau PET, and also by FDG PET, allowing the assessment of neuronal injury. FDG PET is to be considered the best established imaging biomarker for neurodegeneration, providing some kind of information in basically all kinds of neurodegenerative disorders. FDG PET is a measure of neuronal injury, and characteristic findings have been described for the different types of neurodegenerative disorders, as we can see on top of this slide here. However, one specific neuropathology may result in different patterns of neuronal injury, and also different neuropathologies may result in similar patterns of neuronal injury. So an etiological diagnosis is not always possible, but increasingly important with the advent of new causal therapies. So there's obviously a need for etiological imaging biomarkers. In this context, we have biomarkers available now, such as the amyloid imaging tools. There are three different amyloid imaging biomarkers currently approved by the FDA and the EMA, all of them also commercially available. By autopsy trials, it has been confirmed that these biomarkers have a high sensitivity and specificity for proving the presence of amyloid aggregates in the brain. This has a particularly high negative predictive value, meaning that if there are symptoms present but no amyloid is detected, the probability that this is Alzheimer's disease will be very low. On the right side of this slide, we can see typical findings in a healthy control subject without any distinct uptake in the cortex. In the bottom row, we see a typical finding in Alzheimer's disease with intensive uptake of the tracer in the cortex, reflecting amyloid plaque deposits. What about the value of amyloid imaging for early diagnosis or prediction of Alzheimer's disease? It has been demonstrated that about 20 to 30% of subjects above the age of 60 years show some amyloid aggregation in their brain even without any cognitive symptoms. However, from this finding, not easily a risk for conversion to Alzheimer's disease in the near future can be derived, as we can see on the left side of this slide. Amyloid positive healthy subjects have been shown here to show a conversion to mild cognitive impairment within 5 years in a percentage of about 20%, meaning that the rest of the amyloid positive healthy subjects in that group did not show decline during this period. It looks different for patients with onset of cognitive impairment, as we can see on the right side of the slide. Here demonstrated for patients with mild cognitive impairment, a relatively high proportion of these subjects showed a conversion to manifest dementia of the Alzheimer type within 5 years, reflected in a high sensitivity for prediction in these patients. Recently, more evidence has been collected on the value of amyloid PET imaging for early diagnosis. This refers to the so-called Amyloid PET trial, the largest European randomized controlled multicenter prospective study on amyloid PET in clinical practice. In the first branch of this trial, patients were randomized to receive amyloid PET or not, and it has been demonstrated that in the subjects who did receive early amyloid PET in their diagnostic workup, a diagnosis with very high confidence was possible in 40% of cases, whereas this was only possible in 11% of cases of patients without early amyloid PET. Also, a change in diagnosis has been resulting from amyloid PET imaging in the first population. This study also included MCI subjects and even subjects with subjective cognitive decline, meaning they did not have any objectifiable cognitive impairments. The second branch of this trial included healthy control subjects who were stratified according to results in their amyloid PET scan. Here it has been demonstrated that the baseline amyloid burden was associated not only with cross-sectional cognitive performance, but also with decline in cognition and brain atrophy over time. Also, it has been shown that thresholds can be defined which are associated with functional decline over time. What about the value of amyloid PET imaging in differential diagnosis? Here we can divide between two categories of potential value. One is the detection of atypical Alzheimer's disease. And we see here three examples of atypical Alzheimer's disease: posterior cortical atrophy on the left, logopenic aphasia in the middle, and the frontal executive variant on the right, as reflected in their FDG PET scans with very different patterns of neurodegeneration. All three of these cases did have a positive amyloid PET scan, as we can see in the bottom row of this slide on the left side. So these patients showed different phenotypes, but the same pathology underlying their cognitive impairments. The second category of differential diagnostic value is the exclusion of pseudo-ID, meaning patients looking like Alzheimer's disease from their symptomatic appearance, but suffering from other causal neuropathologies. In this context, the so-called IDEAS trial is of great value. This was the largest trial so far performed using amyloid PET imaging, including more than 11,000 patients. This trial showed a change in diagnosis in 25% of cases which were suggested to suffer from Alzheimer's disease and were changed to non-Alzheimer's disease after their amyloid PET scan. That means that in these patients, the symptomatic appearance resembled Alzheimer's disease, but the biomarker test disclosed that they are suffering from another causal neuropathology. A change in management resulted also in more than 60% of cases here. So these patients had the same phenotype of symptomatic appearance, but different pathology, and amyloid imaging has been demonstrated to be of value here. What about the quantification of results? The typical approach in interpreting amyloid PET imaging results so far is based on visual assessment of amyloid positive or amyloid negative findings. However, the data can also be quantified, and for that purpose, the so-called centiloid scale has been introduced. This is a sort of standardized exchange rate of the SUV values into a scale ranging from 0 to 100, where 0 would be the mean value detected in a group of young healthy controls, and 100 would be the mean value detected in a group of manifest Alzheimer's disease patients. The elegance in this approach is that different amyloid PET tracer results can be translated basically into the centiloid values, and by that also compared with each other. And this also has been recently integrated in the package inserts of the amyloid PET tracers, where it says now that quantitative information can be used as an adjunct to visual interpretation. For absolute quantification of PET data, we usually would require dynamic PET data, but this is of course burdensome for patients. But again, also in the AMI-PET trial, it has been demonstrated that this can also be done by the so-called coffee break protocol, meaning that an early time window is acquired and combined with a late specific time window, and the patient can leave the scanner in the time in between. This has an additional advantage because the early time window also can be used as a substitute for FDG PET, as demonstrated on the right side of this slide, because the perfusion signal acquired in the early phase here resembles the FDG PET information quite obviously. So moving to tau PET, there have been several tracers now also introduced for tau PET imaging. A single tracer of them, the so-called Fluor tau CPR, is FDA approved since May 2020. So far, an EMA approval has not been achieved. Again, for approval, autopsy trials had to be performed, demonstrating high sensitivity and specificity values for this tracer with regard to the detection of tau pathology in the brain. On the right side of this slide, we see typical examples of a healthy control subject with no uptake in the cortex, whereas we see an Alzheimer's disease subject in the bottom row with distinct tracer uptake in the brain reflecting tau pathology. What's the value of tau PET for early diagnosis in prediction? Again, there have been some studies now performed demonstrating some value in predicting cognitive decline in cognitively healthy subjects, as demonstrated on the left top side of this slide. And also it has been demonstrated that there is a value for prediction of Alzheimer's disease in subjects with mild cognitive impairment, as demonstrated on the right side of this slide. Importantly, these findings all referred to populations who were amyloid positive. So a high predictive value was observed in cognitively healthy subjects who were at the same time amyloid positive, not only tau positive. And the same is correct for prediction in mild cognitive impairment. We will require prospective studies to study the value of tau PET for prediction in the future. What is the value of tau PET for differential diagnosis? Tau PET may have additional benefit here, as it not only demonstrates the presence of a pathology in the brain, but also the location of the ongoing neurodegeneration, as we can see in the top left corner of this slide here. We see patterns of tau aggregation here in typical Alzheimer's disease, but also in the frontal type, in posterior cortical atrophy with a distinct occipital uptake, and in the logopenic variant of progressive aphasia. These results are different from amyloid PET imaging, which would show relatively homogeneous distribution of amyloid pathology also in the atypical variants of Alzheimer's disease. In the left lower corner of this slide, we see tracer uptake in a patient with progressive supranuclear palsy. This is a so-called 4-repeat tauopathy, which is different from the tauopathy found in Alzheimer's disease. And there are studies ongoing recently with the next generation tau PET tracers, who are suggested to have a value also with regard to detection of this kind of 4-repeat tauopathy. Again, the pattern of distribution is important here. Studies also demonstrated that amyloid positive and amyloid negative subjects can be differentiated on the basis of their tau distribution pattern, as demonstrated here in the middle of this slide. This has been a deep learning algorithm in which it has been demonstrated that nicely amyloid positive, amyloid negative, and tau negative subjects could be differentiated on the basis of their tau PET findings alone. Last not least, again, as for amyloid imaging, the early phase of tau PET imaging can be used as a substitute for FDG PET. So taking it all together, it appears that tau PET may in the future serve as an universal biomarker tool, providing some information on A, T, and N status of the patient in a single scan. What about visual and quantitative assessment of tau tracers? Again, the visual read of tau PET scans would result in a tau positive or tau negative results. Importantly, a positive tau scan would support the presence of widely distributed tau neuropathology. Scans with uptake in the mesial temporal lobes or minor uptake in frontal cortical or anterior temporal cortical regions would not be considered as tau positive in the sense of widely distributed Alzheimer typical tau neuropathology. Also recently, semi-quantitative assessments have been introduced, as we can see on the right side of this slide here, with the so-called Centaur scale. This would be the analog to the centiloid scale presented for amyloid imaging just before, and presumably could again result in a more standardized quantitative readout, also allowing comparison of different tau PET tracers. There have been appropriate use criteria published before, by that time referring only to amyloid PET imaging. The indications for amyloid imaging here were listed as progressive, persistent, unexplained mild cognitive impairment as one. Second, possible Alzheimer's disease. The emphasis here is on possible, which does not include probable Alzheimer's disease. And the third indication would be patients with early onset of cognitive impairment, meaning below the age of 65 years. It was considered inappropriate to perform amyloid imaging in patients with probable Alzheimer's disease with typical age of onset to determine dementia severity instead of genotyping in asymptomatic individuals or for non-medical usage. As these criteria have no longer been considered to be fully appropriate with regard to the current state of knowledge, an expert work group has been assembled trying to find new appropriate use criteria, now referring to amyloid and tau PET. And this is currently still work in progress. The additional indications here for amyloid PET and also for tau PET imaging would be the inclusion of patients with onset of the disease at 65 years of age or older, as it has been demonstrated that also patients with probable Alzheimer's disease with a regular onset in a relevant proportion would not show amyloid accumulation in their brains. Also, it has been included as an indication to inform on the prognosis of patients presenting with mild cognitive impairment due to clinically suspected Alzheimer's disease pathology. For amyloid PET imaging only, indications have been included now for subjects with equivocal or inconclusive results on recent CSF biomarkers, and of course to determine eligibility for treatment with the new approved amyloid targeting therapies. Additional indications for tau PET only have been added to inform on the prognosis of patients with dementia due to clinically suspected AD pathology, as tau aggregation in these patients still correlates well with the progression of disease. An important question is the value of the PET biomarkers as compared to the CSF and recently also blood biomarkers. In general, one can postulate that the fluid biomarkers rather reflect an indirect measure of the activity of the pathological process ongoing in the brain, whereas the imaging biomarkers reflect the extent or status of the neuropathological damage in the brain directly. But importantly, also both of these biomarkers do not correlate linearly, as we can see on the left side of this slide here. What is quite obvious is that the levels of A-beta in the CSF, indicating amyloid aggregation pathology, decline quite early, whereas the PET levels still appear normal, and only if levels go below a certain level, the PET biomarker abnormalities appear to increase. And this may reflect a temporal offset of the value of the two biomarkers, indicating that the early onset and progress of soluble or dynamic aggregation pathology in the brain cannot yet be judged by the PET biomarkers, as we can see on the left side of the diagram on the right half of this slide, whereas the onset and the extent of aggregated pathology burden later on can be judged by PET, but not by the fluid biomarkers, which have reached a plateau by then. With regard to this information, we may want to come up with a new biomarker classification concept, differentiating between the soluble biomarkers and the aggregated biomarkers of amyloid and tau pathology, as summarized on this slide here. With this, I want to move on to a case example. This refers to a 72-year-old man who had difficulties in reading, orientation problems, and issues with driving his car and using tools. The neuropsychological tests demonstrated visual impairment, but only minor impairment in memory. If we look at the imaging findings, we see the FDG PET here on top and the tau PET evaluation in the bottom row. What's quite obvious is that on the FDG PET scan, hypometabolic areas appear in the bilateral parietal and also occipital cortical regions, which is also nicely reflected on the surface projections. The tau PET scan looks like a mirrored FDG PET image, where we can see distinct accumulation of the tracer again in posterior parietal and occipital regions of the brain bilaterally, in rather the same distribution as demonstrated for the hypometabolism on the FDG PET. So the question here would now be, what is the correct answer? 1, the patient probably has a positive amyloid scan. 2nd, the patient needs to see an ophthalmologist. 3, the patient probably has an abnormal dopamine transporter status. Or 4, the patient suffers from an encephalitis. The correct answer here would be number 1, the patient probably has a positive amyloid scan. And this is explained as follows. The diagnosis here is posterior cortical atrophy. And as mentioned before, posterior cortical atrophy is an atypical variant of Alzheimer's disease. The patients often show non-memory complaints, particularly a decline in vision and literacy skills, and they frequently have futile visits to ophthalmologists in their patient history. The amyloid PET is positive because this is an atypical form of Alzheimer's disease. FDG PET in these cases often shows distinct posterior parietal and occipital hypometabolism, often still sparing other regions of the brain. And the tau PET, as we can see, shows a similar pattern of increased tracer retention in the affected areas, demonstrating that the neurodegeneration occurs in exactly these regions which are tau positive in the brain. Amyloid PET, as demonstrated in the right lower corner of this slide, is positive, but quite generally all across the brain, not only limited to the neurodegeneration affected regions of the brain here. With this, I want to thank you very much for your attention.